All right.
Hello to everyone. Welcome to this presentation by Dr. Wolfgang Liedtke on medical treatment of facial pain. My name is Jeff Boddington. I'm a director of the Facial Pain Association, and I'm your moderator for this presentation. I'm pleased to welcome Dr. Liedtke. He is chair of neurology, ophthalmology, and pain medicine, and a member of the Global Development Scientific Council at Regeneration Pharmaceuticals. Prior to that, he conducted basic science pain research as a tenured professor in the Department of Neurology, Anesthesiology, and Neurobiology at Duke University. He is also a member of the FPA Medical Advisory Board. We're glad to have him. Thank you for joining us, Dr. Liedtke. Before we get started, I'll ask attendees to submit questions through the audience Q&A feature on your screen. We'll get to as many of those as we have time for. Now I will turn it over to Dr. Liedtke.
Thank you very much, Jeff. And can you hear me, Jeff? Is that working?
I can hear you.
Great. Okay, well, great to be here. Thank you so much for the kind introduction. And let's go to the presentation. There we are. So I'll give an update on medical treatment of trigeminal nerve pain disorders and other painful cranial nerve pain disorders, which has kept me busy during my 17-year career at Duke. And I am at Regeneron, which is a biotech pharmaceutical company that is just north of New York City. And I'll give you a bit of an intro what we do. I also joined the College of Dentistry at New York University, where there is a hopefully impactful group of pain researchers, and I have joined them also. I remain also with Duke, but my main professional route is Regeneron, where I serve in an executive function. And let's go to the next slide. Okay, so this is a COI that I want to know. Regeneron is my employer. I'm adjunct faculty. These are my own opinions. I'm not representing Regeneron, Duke, or NYU here. Co-founded a biotechnology company that aims to make topical medications. And this is an informational overview, scholarly, educational, not medical advice to distinct patients. No concrete medical measures for specific patients are presented here. So who am I? I am an investigator with a root with two legs, and I consider myself a true bipedal. One of my legs is in the laboratory, in the research laboratory, where we have investigated pain mechanisms, pathologic pain mechanisms, chronicity mechanisms for all pain, and also specifically for trigeminal pain. I have also treated patients over my 17 years at Duke, and before that, when I was a physician in Germany, patients suffering from pathologic pain, especially head and neck pain. And I have united these, and I have walked the walk on my 2 feet. And I have now become, since 2 years, a biotech pharma executive at the leadership level of Regeneron, which makes medicines based on a corporate logo of science to medicine. That's what brought me in. So I'll give an update on what can be done in terms of a medical treatment for trigeminal pain and glossopharyngeal pain and other chronic craniofacial pain that have become trigeminal or glossopharyngeal. So as mentioned by our previous speaker, Dr. Pilisis, Dr. Darnall, this is a integrated approach where medical treatment takes place amidst other options, amidst other choices. And I want to elaborate in this talk a little bit what critical elements medical treatment for facial pain should incorporate or might incorporate, but that is to be viewed against the management strategy that is implemented between the patient and I'd say the team or the specific doctor who takes care of the trigeminal pain once it is clear that that doctor and her or his practice will be the ones who manage it, then in consultation with others. So medical management has a place. It needs to be diligently and carefully established where that place is in the entire management regime. That being said, there is one element of medications for facial pain which I always made sure that all of my patients have that available for them, and that is there needs to be an as-needed medication for attacks and for the episodically worsening pain. There's a central element of trigeminal pain that there is episodic worsening and there are attacks. And that is one reason why the pain has a unique standing, why it is so horrible, in that it overwhelms the patient with the supramaximal pain sensation that they experience. And it's coming out of a background of lesser pain or no pain. And that leads, together with the human brain, to an element of learning, which is not good for the patient who experiences that. And therefore, to me, it was very clear that trigeminal pain with episodic worsening and attacks incorporates an element of post-traumatic stress disorder. No question about that. And that sets it apart. That is one clinical feature that sets it apart from other forms of pain, which are horrible. Also, of course, lower back pain, refractory cancer pain, abdominal pain, bone pain, etc. It's not to say that, oh, this is good. They have specific qualities, and one quality of trigeminal pain that needs attention is the episodic nature or the attack nature. What do we do against that? Because if you have a tablet that you swallow, it will be too late. It will not do something about it when the attack announces itself. And that is, fast-acting medications are needed for attacks for episodic worsening in case the attack, the episodic worsening, is announcing itself, in case a patient has some pre-warning. And I'd say the minimum that needs to be there is something in the order of seconds that allows such a as-needed medication to be implemented. So let's go through them and explain what I mean. And you will see that these fast-acting as-needed medications, they will get at the pain through different mechanisms, and that is good. That means that in case one approach is not really doing it, that they can also be combined. And here's a little bit of a color scheme that I want to guide you through on this slide, which is if something is depicted in blue here, blue bold or blue non-bold, then it means it's a controlled substance. And the patient will have to speak to their doctor about a controlled substance being used, which to me was always, well, it's a formal hurdle. And if it is needed for the treatment, we'll do it. But it has certain formal requirements that need to be arranged for and discussed through between doctor and patient. I do know that there are some colleagues who have a higher threshold at prescribing a controlled substance for the benefit of the patient and sort of shy away or are not as, for them it's not the same as if prescribing a non-controlled substance. And to me, it always was. And the guiding principle should be here pain relief, and if a controlled substance will do that and a non-controlled substance will not do it or not do it as well, there's no choice. But the reality might be a little bit different, and it needs to be navigated by patients. Okay, so controlled substance, bold, needs a compounding pharmacy because no company in the world makes it, and this is bold in black or bold in blue. And then finally, italics, cursive, means that you will run into hurdles getting this approved, or if you pay out of pocket, that could become expensive to a degree of possibly forbiddingly expensive. But that's the reality, and we cannot wish that away. So start with, standard treatment. Core of it is fast-acting antineuralgics of a type of carbamazepine or oxcarbazepine, and they can be made fast-acting by being chewable. There's a chewable preparation for that. There's a liquid preparation for oxcarbazepine, and they are they are good. Every patient should have that and try it and see whether it is possible to reduce these attacks and bring them down as early as possible. Next is something that I'd say is perhaps second choice to that, but worth a trial if the first doesn't work or is counterindicated. It's GABA. It's liquid gabapentin, the third. So that's also a non-regulated substance. Liquid gabapentin is an alternative to carbamazepine, oxcarbazepine. Then completely different from that is the benzodiazepine of a type of clonazepam, which is particular particular feature to be effective against trigeminal pain, whereas diazepam and lorazepam do not. And there's some peculiarity about clonazepam that doctors who treat trigeminal pain know, and that's not clear scientifically. So if you want a mechanistic explanation for that, sorry, it's not there. Clonopine can be prescribed as orally dissolving. That means it works really fast and it gains access to the body through the tongue and through the oral cavity, which is trigeminally innervated. And then also a word to the dose is 1/8 or 1/4 of a milligram, and the lowest dose of a tablet is 0.5 milligram. So 0.5 milligram or milligram, if you don't have pain, will make you tired for sure. If the pain is coming, 1/8 or 1/4 of a milligram might have no effect in terms of sedation. It's just very helpful in terms of bringing the pain down. I made the experience that liquid trileptal or chewable carbamazepine works well together with clonopine, and patients figure out take this first and that second, and that's a way to bring down an attack, and to bring down an attack to 10 or 20% of its intensity. And if you can manage that, that's great. Okay, liquid gabapentin, we have it. Now we come to something more new, which is repurposing from the world of migraine treatment, so-called GPANs. That's a drug class, GPANs, and you see one of them a little bit older is rimegepant, and the newest kid on the block is savegepant. So we have GPANs, rimegepant, savegepant, and they have been formulated for treatment of migraine with the same idea, rapid, get it into the body of the patient like quick. Is as a orally dissolving tablet, rimegepant, orally dissolving tablets for migraine. Big commercial success for the maker, which has now been bought by Pfizer. Pfizer bought it, and Pfizer also makes savegepant as a nasal spray, just approved by the FDA early in March. So it's really, really new. Not clinically trialed out that we have, this is significantly working, etc. This is more anecdotal that patients of mine and patients of my colleagues liked rimegepant orally dissolving. Works great for some, or I'd say for the majority of those who have tried, there is some relief out of that. Yes. And then likewise now is a nasal spray that might be even better for faster onset and for reaching the second branch of the trigeminal nerve better than through the oral cavity. So I have even the one spray goes to second branch, oral dissolving goes to the third branch. One row down, ketamine nasal spray, much older drug, ketamine. Yeah, but formulated as nasal spray has recently made a transformative advance in the treatment of depression and came on market as a medicine called Spravato, which is esketamine at that concentration. And that is really hard to get for patients with trigeminal pain. There needs to be a depression, severe depression, comorbidity. The prescribing doctor needs to be a psychiatrist. That's tough. The way out is prescribe ketamine nasal spray through a compounding pharmacy at a little bit lower concentration, which all the compounding pharmacies can do. It's a controlled substance, but it's very fast acting and has a unique way to get at the pain, totally different from all the others above. And therefore, that's something where I'd say that can be very, very beneficial. I have made great experience with ketamine nasal spray. There was a very popular prescription in my practice for that, like as needed medication to prevent attacks. Can be combined with all of the above. Okay, next one. Also, compounding pharmacy, oxytocin nasal spray is overall comparatively weaker compared with everything else that has been indicated here, but it can, for some patients, be really, really good. And also, I'd say it combines really, really well with either of the standard approaches above. Finally, I also incorporated new to the presentation from last year, lidocaine, local anesthetic, so numbing, a numbing spray, numbing nasal spray or numbing jelly to be taken inside the mouth. And I have not used that so much, but I noticed a publication that seemed to be well done out of China, where there is trigeminal neuralgia and it's a management problem just like here. And they reported that lidocaine jelly, lidocaine spray was a beneficial way of dealing with attacks by providing a temporary numbing of the site where the attacks will strike, which means if there is a second branch pain, you need a nasal spray. If there is a third branch spray, you need to take the jelly or the solution inside the mouth. And that gave like 15-20 minutes of cover when then the action resolves. And that could be all you need for, taking, taking some carbamazepine or some trileptal that is fast acting by taking a tablet, and it starts acting. So the local anesthetic will cover you. Low tech and inexpensive approach that might very well be worth it. I have shied away from it because I was always worried if the local anesthetic stops working, it eases off, then it might trigger a rebound. But then you can prevent the rebound with other medications that is being taken while the lidocaine is having the numbing effect. So plenty of options here. Patients need to have that. And currently it is that it needs to be trialed out patient by patient, what works for them, what they can manage for themselves to have this. But surprisingly, many doctors and clinics who deal with this are very surprised when mentioning this. And I strongly believe every patient should have a means to prevent attacks and worsening. There's another directly linked physiology, pathophysiology when attacks happen, which is blood pressure goes up. It's so painful. It's supramaximal pain. Blood pressure goes up. Blood pressure going up is bad for trigeminal pain, so that you can easily envision bad pain begets worse pain. Worse pain begets pain that is even worse. So it's spiraling out of control, a real pain crisis. So you want to hit the pain, of course, but how about bringing the blood pressure under control? Because there could even be, with many attacks, you don't want these blood pressure peaks hitting your brain. So unfortunately for blood pressure, there is the landscape for hitting that with this rapid onset and rapid pharmacokinetics is not as lively and as varied as for pain. And so fastest acting tablet is captopril, old medicine, 25 milligram. That starts working about 15 minutes. With attacks happening, it's worth for patients to be cool in that moment, if possible, and measure your blood pressure. Are you somebody who has an overshoot of blood pressure going up during the attack, or are you experiencing that supramaximal pain, but the pain fortunately leaves your blood pressure not so much going into this, supramaximal territories as well. And if there is a blood pressure problem associated with the pain, I strongly recommend to also have a medication that can help with blood pressure peaks with pain attacks. So captopril fastest, clonidine 1.1 milligram, also suitable, a little bit slower than captopril, but clonidine itself could be good with pain. And then next one here in bold, clonidine nasal drops. So there you have a nasal application of an antihypertensive that you need to have made by a compounding pharmacy. Is fast acting, but then doing a little bit of literature review. The problem with that is an inconsistent absorption from patient to patient. So it's a very varied pattern. What happens if you take 10 people or 20 people and they nasal spray it or they nasal drop it? But that to me is like, okay, that's worth a trial. The worst is like no good absorption, then it doesn't work. But if there is good absorption, then it works and you use 0.1 milligram, and there you have your fast-acting blood pressure medication that also acts on pain. But I didn't find any studies, any data that were reported on that. Okay, adjunct sedation, it's not an antihypertensive, but it will help because it will lead to some level of sedation, the orally dissolving benzodiazepine like clonopine. But here also comes lorazepam, which is a relative of diazepam, clonazepam. Liquid lorazepam is good for that. It's like an anti-panic medicine that we borrow from emergency psychiatry. All right, that was that. Really important. Every patient should have that. And if there are doctors are surprised about that, maybe need to be educated. But to me, it's a no-brainer. Okay, regular medication that is taken in regular intervals, daily take to manage pain better, to reduce attack frequency, attack severity, etc. So here we have the biggest group is sodium channel inhibiting compounds led by tegretol, carbamazepine, oxcarbazepine, trileptal. That's a standard that's approved clinical, that's FDA approved, and or has study data to it that say it does work in studies of the highest clinical degree, etc. These medications are good, they are fine, but they also have problems with it in that therapeutic window is not too large. That means side effects start happening. Many patients who take this medication in doses that help them with their pain are not too happy with that overall profile, and therefore rather endure pain, which to me is extremely telling that these medicines are better than nothing, but it's not good. And there are many doctors have cultivated a practice of being really good at titrating and talking the patient into enduring these side effects, etc. So honestly, I have taken a slightly different route in my practice which is I have switched as much as I could, and to those who were responders, which most were, patients to treatment with lacosamide, which is an anti-seizure medication, lacosamide, and I have put them on lacosamide, and I listed here as the most potent. Vimpat is a trade name. Vimpat, lacosamide, anti-seizure for treatment of management of epilepsy. Most potent sodium channel inhibitor that can be prescribed, best safety, TME to my estimate. There's also a bit of a problem at gaining approval for this treatment, but there is also the company that makes this medicine has a support program for patients where if you fall under a certain level of income, they will, if you fulfill certain criteria, they will provide the medicine for you essentially for free. It's a bit of paperwork, but I did that many times because the drug is so good. Never managed to write up my beneficial experience with my patients, but now publications are appearing that are fully supportive of my take, which I have had over the years, shared that with colleagues. Colleagues also do it. I heard similar stories, similar experience from others. So lacosamide fully endorsed from my end if there are problems with those carbamazepine-like drugs. Zonisamide, Zonegran also inhibits sodium channel. It's a bit weaker than the above, but there is one point to be made in that Zonegran for sure will not have a side effect of making you heavier and increasing your body weight. It might even support if you have an intention of body weight going down. And here I mentioned low sodium that happens in response to carbamazepine oxidase is horrible complication if you run into a low sodium, so-called SIADH syndrome, because then with sodium going lower, carbamazepine will stop working. And that is you take more carbamazepine because pain is not controlled. Sodium goes down, you take more carbamazepine because pain goes down, and makes the low sodium worse. So that can be really, really a very, very challenging condition that has to be met with intensive care. And I've seen it. So lacosamide and Zonegran are less frequent, much less frequent to have this complication of SIADH caused by carbamazepine or oxcarbazepine. That is sodium channel. That to me is a mainstay of pharmacological treatment for facial pain, to sort of put the lid on it with a sodium channel inhibitor if possible. There are about 10% to 15%, just roughly over the thumb, of patients who don't have a good therapeutic response to those sodium channel inhibiting compounds, which indicates that trigeminal nerve pain is not homogeneous. Not 100% of patients respond to this. There is a percentage, a minority, but there is who do not have this beneficial response. That means their pain is not driven by overactive sodium ion channels or nerve cells, which is that's an important science feeder, how this works or how this not works. So for those, and in addition to the sodium channel inhibiting compounds, gabapentin and pregabalin, gabapentin is a generic, pregabalin is Lyrica, can be used and have been used with wonderful effect in a number of patients, but not for all. Pregabalin can lead to weight gain, sometimes almost explosive, and also sometimes is not so easy to wean off if it comes to that. But I have had good successes with both, and in most cases it was like a second medication or third medication adding to a polypharmacy regimen. Down there, lamotrigine perhaps underutilized because when using it needs to be slow dosing in, which is about 100 milligram. It starts with 25 milligram and then goes up to, you reach 100, you reach 100, can become 200. This is a spiel over several weeks, several months even, and that means that is certainly not when the pain is raging. You cannot come with lamotrigine and say, well, 3 months later, you'll be on the full dose. But if that is a part of the strategy, it can become a very, very helpful component to balance the medical regime. And you hear here that I'm a firm proponent of polypharmacy. I do not think that severe and hard to manage trigeminal pain will be managed with one drug, which could be a bias because over my years at Duke, I have only seen those that were perhaps not manageable by the one drug approach, and the one drug approach patient never came to my attention because they were successfully managed by other doctors. So with that bias, which I'm aware of, I'd say, well, if one drug doesn't work, you need to resort to polypharmacy, and that can oftentimes be very, very beneficial and has changed many lives. Okay, what else can be in this polypharmacy is medicines we borrow from psychiatry, and indeed, then the medicine turns out to be even better in the pain world than with psychiatry, but what you're looking at, none of this is specific for trigeminal nerve pain. These are medicines that are good with chronic pain, chronic nerve pain associated comorbidities, things that are not good health-wise. And let's go through them, where first, the largest group here is derivative of Prozac. As we are referred to as a Prozac nation, we have quite a choice here. And one of the Prozac ears was duloxetine Cymbalta. And it was soon found that Cymbalta is not such a good, not such a strong mood medication, psychiatric medication, which it is also, but it's quite formidable anti-pain, anti-nerve pain. And that is so it is an SSRI as NRI, and that RI means reuptake inhibitor, and it means that whatever it is not reuptaken by nerve cells becomes a little bit more. And so SS is selective serotonin and SN is selective noradrenaline. So those are neurotransmitters which are increased in their abundance and increased in their impact when taking this medication. And so duloxetine acts on serotonin and noradrenaline. And that is the key difference to Prozac, where Prozac is SSRI almost entirely. So that Prozac good for mood, some pain indication like perimenstrual migraine also good, but trigeminal pain rather not. Whereas duloxetine Cymbalta as an add-on is very helpful, and I have prescribed it a lot. And for example, typical example, post-herpetic trigeminal neuralgia after zoster. Zoster happens, unfortunately, lesions heal, and then neuralgia develops in the trigeminal territory where the zoster affected the patient, particularly an elderly patient. So refer to me, nothing helps. So there's a good deal of these patients whom I did help with gabapentin or Lyrica plus Cymbalta. It's like, I don't want to call it magic mix, but gabapentin doesn't work, Cymbalta doesn't work, but if you put them together, bang, you got a really good effect on the pain, and that's a typical experience I made. Venlafaxine as an alternative to Cymbalta, that is also not clear scientifically why that could ever work, but venlafaxine can help with pain where duloxetine is not so good, not so strong. Those are older SNRIs. Then vortioxetine is a bit newer, and I have also seen that vortioxetine can be a step up from either. Then a little different from those is mirtazapine. Mirtazapine has an effect, can enhance weight. So with that, there are sometimes trigeminal nerve pain patients where that is something one wants. But on the other hand, more than those who have low weight, there's an uptick in BMI, and for that reason, mirtazapine for those is not so helpful. And then milnacipran, another special flavor of these SNRIs, is a further development from duloxetine, and it has found a niche or is particularly more active in cases of nerve pain that is related to fibromyalgia. And for that reason, milnacipran is perhaps a tick over duloxetine for those suffering from fibromyalgia, which is mostly women, but there are also male sufferers from fibromyalgia as a pain predisposing another medical condition that can make pain more likely and more severe. Last one here is bupropion. That is borrowing from psychiatry for mental health comorbidities, seasonal affective disorder, people weaning off substance of abuse that might be in the picture, want to wean off drinking, want to wean off smoking, which smoking for trigeminal pain, of course, don't do it. But if there is a cigarette addiction together with trigeminal pain, what you do? Well, you will use bupropion. This, interestingly, is a so-called NDRI. So noradrenaline, D is dopamine. So dopamine makes the world go round. Dopamine is a substance of reward. And so dopamine is slightly increased here with bupropion. So with that, it can enhance wakefulness also. So sometimes with coexisting brain fog, I have also tried that. Not bad, but there are other ways we can try to deal with brain fog. Cannabinoids come out big with cannabis becoming more legal around the country, such as New York City, where you can smell it if you walk around. But that people with trigeminal nerve pain have tried cannabis invariably, and I heard their reports reporting back to me. It's not a panacea, and if it were, many more, or not, if not all, patients with trigeminal pain were using it, and they are not. Can be prescribed as Marinol. There will perhaps be more cannabinoids coming for prescription, and so Marinol can be prescribed. I have prescribed it typically as a third or fourth line agent, and there were some patients who really liked it, who stayed on it for years. It's also a controlled substance, so it will have to be pushed through with approval, etc., etc. Slow dose in is needed. Cannabinoid side effects can make people sluggish, can also make people gain weight. That's definitely a baddie or a no-no. Or if it is desired, then it's really good, and I would higher prioritize it in case weight gain is a co-goal of treatment here. All right, anti-inflammatories, not to forget, because with nerve pain, it is said, oh, it's nerve pain. This is not inflammatory pain, but that is a scientific premature conclusion, I'd say, where trigeminal nerve pain has more inflammatory roots than previously acknowledged, and so therefore indomethacin is very powerful, very old drug, very powerful, but with that is chronic application of indomethacin is problematic. So if the perspective is months and years of indomethacin every day, that's not suitable. But if it is that there is, for example, a worsening of the pain that is known in spring, with some allergies that go with that, in that case, one second, I need to switch off this alarm here. 1 second. Okay, so the anti-inflammatories can be used for long-term use with meloxicam. Okay, and I'm coming to an end here. So, but that one medication I do want to mention here as something that has changed many lives in my hand is low-dose naltrexone. In my hands has changed many lives. Low dose in mechanism of action MOA is not known, related to endogenous opioids, related to glial cells in the brain, but not really known. The kicker, or the most important thing, is low-dose naltrexone has a side effect profile similar to placebo. And that means you gotta try that. And again, many lives changed in my hands using low-dose naltrexone. Takes a while for it to kick in. Chronic use of nasal spray with oxytocin and with ketamine can be tried as for treatment of attacks for enhancing chronic management. Then what I also have prescribed and implemented in my patients is the anti-CGRP monoclonal antibodies that need to be injected, self-injected, which is 3 of them that can now be prescribed against migraine, chronic migraine headaches, where insurance acceptance of these scripts has become better. And I did notice that they are providing some decent foundation against trigeminal nerve pain. They're not eliminating it, but it is a worthy component of a multi-drug regime. And again, has to be pushed through with the insurances, and perhaps future use will be hopefully there will be studies with higher doses, where we know from cluster headache that you need about almost 3 times as much galcanezumab than you need for migraine. And maybe trigeminal pain has a similar story to tell. So needles, people are afraid of needles. I haven't seen that much in my practice, but there are. So there might also be good news in the future in that skin patches will be used that contain so-called microneedles to get this medicine, this protein medicine, these antibodies under the skin, because of course, or you cannot, or you can swallow them, but it in that case would be completely useless. All right, opioids, if helpful, use them, don't have a prejudice against them. Low potency opioids can be managed, and low potency opioids appear essential. In that case, consider methadone, butorphanol, old opioid medications that can be used for long-term management, levorphanol as well. So 3 type of opioid-related long-term treatment suitable medication that can be used. Methadone can be liquid, is also inexpensive, and it allows for example, low-dose methadone, ultra-low-dose methadone. And I have had patients who needed this and who were doing very, very well with it. Okay, fight comorbidities like this fighter in the upper right, and perhaps to mention here, inflammatory comorbidities, where there is inflammation next to the trigeminal nerve, such as in sinuses, or also remotely like rheumatoid arthritis, inflammatory bowel disease. Obesity is also a condition where there's a significant amount of systemic inflammation happening, fueled by the excess adipose tissue. And I would advocate, or strongly advocate, to also think about that and to also go after that in the longer term management. Local issues with inflammation can also involve the skin, such as atopic dermatitis, rosacea, scalp psoriasis, lupus. Fight it vigorously and aggressively. And that has I have made very, very positive experience with that, where other doctors said, yeah, it's not so bad. Let's focus on the trigeminal pain. The trigeminal pain didn't respond, so I focused on the comorbidity and gave that more attention, treating more aggressively. And that was the key to making really significant progress for patients. Okay, examples here: dental comorbidity, broken jaw of the dental implant, tumor, meningioma impressing on the trigeminal, orbital pathology here in a young girl. Go after them with your partners, with doctors who can help. There's intravenous medication that can be done in the urgent care setting that I have listed here. My talk will be posted, and I'll skip this for this last slide, which says, from the side of doctors, clinics and enterprises need to be built that really adapt to this form of pain, which is interdisciplinary. Nobody owns trigeminal pain. That is not the subject of one medical specialty. She or he suffers should never ever land between the chairs, and those who treat, they need to form a team as indicated here, the ladder that stands up against the wall, or the team that wins in the playoffs, or the team that rows the boat to an Olympic medal. That's what we need to do when we are on that side. We cannot be lonely wolf fighters. And we also need things like pain administrators, pain lawyers, pain public relation people. No question that there is room for improvement at that side. And of course, if you want team, you don't want any type of infighting, antagonism, who is the biggest gorilla in the shop. It doesn't help at all here. All right, so one of the biggest things I have contributed scientifically was work together with my friend Fan Wang, who is now a professor at MIT, and we deconstruct why trigeminal pain hurts so bad in that it can activate and electrify emotional processing centers in the brain, and that is what sets trigeminal pain apart from other forms of pain. Needs to be accounted for when treating it. My point, never give in because you're not alone, and be Spock. Okay, so this is my bold statement at the end of my talk. We will go after you, facial pain, and we will in the end overcome and terminate you. All right.
Thank you, Dr. Leitke. That was very informative. We have had dozens of questions. To address just a couple.
Sure. So Jeff, what I will do is we'll play it back and forth until we run out of time. And as of last year, I have produced a transcript of the question that we're pouring in, and then try to bundle them with interest, etc., and answer to them in writing, and then have that as a post that will produce. I tried to get this done over the weekend, and we'll post it on the FPA website. So if the question is not answered, hold on. I will make an attempt to at least try to answer everything. Okay.
That will be great. Also, your slides will be posted. We'll be sure that people can find a link to that and your answers. That's a great idea.
Great.
What I'd like to do is group some of these questions together and cover a few things in another 10 minutes that we have left. First, is there a DNA or any other type of test or set of tests that would help physicians and patients know which medications are most likely to be effective? Or is it just, you got to try it?
Yeah, not yet. It's something that I wish there were, and I had been able to use it. So it's still old-fashioned and over the doctor's thumb, listen to the story and try to customize the treatment with that, and certain physical features. The patient is, has gained significant weight, so no, don't do that. Or the patient needs to gain weight, then veer with that. Is dominating attack pain, is dominating background pain. So take these simple clinical guidances. The modern day precision medicine, I'd say unfortunately not yet, but it is coming. And in that respect, a colleague from Harvard, Christopher Kahle, a neurosurgeon at Harvard, pioneered the genetic exploration of trigeminal neuralgia, where it's very clear that there are familial cases of trigeminal neuralgia, trigeminal nerve pain. Dr. Kahle collected these in a laudable effort and poured some magic of 21st century genetics over that, and he came up with results. The certain genes were winners from that analysis. It was published, and I do know that this has been the starting point of people working on that. There is a sister association to the Facial Pain Association, the Facial Pain Research Foundation out of Gainesville, Florida, and they are supporting genetics research that will get to this point and to help answer this question that you raised, Jeff. Yeah.
Okay, thank you. We also had a number of questions about anesthesia dolorosa. Are there any medications which seem effective for that.
Yeah, so anesthesia dolorosa, fortunately, not the common complication, which in many instances of that is a result of treatment that
Right.
overshoots or does something of a too much to the trigeminal nerve that is operated in with good reasons and with good intentions. Anesthesia dolorosa ensues. So I have had perhaps a dozen or 2 dozen anesthesia dolorosa patients over the years that came to see me. And what were winning principles in those cases was polymodal therapy. So throw the shop at it in a way that hits it right for the patient. And what were common ingredients of throwing the shop at it was I treated them with injections with Botox. So the hurtful areas were treated with botulinum toxin. Lacosamide, Vimpat was implemented. If possible, low-dose naltrexone was implemented, but there were patients who had to take an opioid, otherwise they had no life. And then taking an opioid is an unfortunate downside of that is when taking an opioid, low-dose naltrexone is not meaningful to be implemented. It doesn't work. So lacosamide, Botox injection, if possible, low-dose naltrexone, and then helpful combination with other things, such as when pain gets worse, to have ketamine nasal spray. Ketamine nasal spray, that was more of a latecomer to my practice. Yes, I would definitely also list that as part of the magic. And then I remember one gentleman, he was suffering from that pretty badly, and he started when I start gaining traction with his treatment, he get back with an exercise regime, which in his case involved swimming. And so I definitely, that gentleman swam his way back to being more functional. He resumed his business, etc., which is an experience I made that if physical therapy in form of many things possible, and I think there's a lot of room for improvement, as Dr. Danal showed that, psychological cognitive behavioral therapy, if you pay attention, you can work on that, and you can claim back things that previously haven't been claimed. Right. And that is also possible with physical therapy. But anyhow, once physical therapy starts getting a hold and the patients make traction with that, I knew, okay, we start winning. And then, go after it and make that part of the treatment as well, where you'd say, well, this is a horrible trigeminal pain condition. What should I do with exercise? Yeah, it's like your fifth. If you have 4 tablets you're taking, this is your 5th tablet. Do it. And it won't work from Monday to Tuesday, but I remember this one case where, he swam his way back to functionality.
We have had a lot of questions about, pardon me, specific drugs and adding or switching to other drugs.
Yep.
Do you have any advice for people about how to manage that transition?
Do it right. And the transition period cannot be that you sort of transition by phase out A, phase in B. And while you do that, you have a valley of, not a valley of death, but a valley of profound stress that allows the pain to come back, which could annihilate a lot of progress that has been made previously. And then that drug A needs to be phased off for some reason. And there needs to be cover. There needs to be analgesic cover during the transition period. And if the analgesic cover has with it, I would err on the side of having low and no pain during that transition, but being a bit sedated. I would err on the side of pain control. If you allow pain to break through during the transition period, it's not a good idea. That could annihilate months and years of progress.
Okay. Another question related to a lot of detailed questions about specific drugs is if one has worked and it's not working as well, or the side effects are getting more intense, can you take a vacation from that drug, transitioning to another one, and then after some period of time, come back
Sure.
and
That is,
find that
yes,
this
that's,
drug is effective again. Does that work, and
that's it.
how does
Oh,
that
yeah.
work?
Yeah. Well, that has even a scientific basis in that the drug will act on something in the brain that makes pain tick, or even on the inflammation circuit that makes inflammation be a bad fire. And then it sort of runs its course and it becomes less effective. Typically, that is not uncommon for opioids, and that can be that opioids are not really helping because they give you in as a form of treatment. What I just shared with Melissa, if you have a treatment that makes people have less pain, happy, oh, I can go, life is back, and then 2-3 months later, the pain comes back with a vengeance. That is medical, is a totally inappropriate form of treatment in forms of medical. That applies to medicines that you take, tablet and whatever, and also procedures. If you do a procedure and people are happy and they say, hey, I'm back, and then 3-4 months later it just returns, it's not good medicine, because it like leaves this false, it's like a pain-free honeymoon, which to me, what I'm thinking about is like medical, in a way, it almost goes toward medical cruelty with trigeminal pain. And that is like so that can be with opioids. If you notice that, then it's like, okay, not for me. But to back to the question, you can have systems, it works on receptor systems or signaling system that exhaust. Then you bring this to a halt through either phasing off or arresting the treatment. The things will recover, and then that what was once helpful can be brought back. And then taking the lesson, don't do it again until it exhausts, but use it as another period of time that it can be used. And you need to have a plan, not a plan B, that, okay, I'm thinking about using this for a limited period of time. When this time period comes to an end, I will do the following. The following will be my option to bridge over that period when I will have to get off the drug that was waning.
Okay.
So it can be made in an intelligent way, that can be made a effective and helpful part of a treatment. Or if we have things like seasonal worsening with trigeminal pain can worsen over the course of a year. In the spring, you can have seasonal allergies. Well, they need to be fought, but it's still. In the summer, you can have like sweltering heat and moisture with a lot of sweating. But then I think most trigeminal pain patients like heat better than cold, because then comes the winter, and if you are not close to the equator, the winter can be harsh and can extol a harsh tax on patients with trigeminal pain. So what do you do in these cases? And then if you have remedies that that you build up and you bottom, you wall up against the pain during the winter or during that period of the year, that's smart. And better do that before it comes. If you know seasonal allergy comes, and start this treatment in mid of February, and then the pollen are coming in March, and you do that until the pollen are gone. And if you have something for that, great.
All right. I think we've got time for just one more question. And why don't we finish with, are there any of these drugs which you think may be particularly a case where people should be aware of psychological side effects, slow them down, make them have bad thoughts?
True.
Are there anywhere you need to be particularly alert to that possibility? And unfortunately, that's got to be our last question.
Well, again, I will tend to the chat board and try to do as a job I did last year, perhaps try to be better. But anyhow, the one I want to bring out here in the first place is that much lauded and praised lacosamide, that I said that it has changed many lives out of my prescription pad, thanks to lacosamide and UCB Pharma, who makes it, who also has this patient support program where you can get the drug for free. Lacosamide, in rare cases, influences thinking, which is a very strange side effect, in that it provokes the patient, or it brings the patient into a situation where they become more and more obsessive. Obsessive in a way that nobody wants it, and it just gets down on patient. And it's a truly psychiatric manifestation of OCD. So it's a drug-induced OCD, and the obsessive component is oftentimes thought about self-harm. And that is so bad that patients have said, oh, there it is, I put it in the toilet, my neuralgia is back. And I rather have neuralgia than that. So that is something. So in most of those in whom it happened, we fixed it by, okay, did something so they didn't have the horrible pain for a while, even if they were sleepy. Then
you change, transition to something else.
Transition to bridge, put a lid on, and bring back lacosamide in low dose because it has helped them so well. And this side effect on obsessive thinking happens down the road, like 3-4 months or half a year. It's not right away. Very strange effect if you think about it. It's a sodium channel inhibitor. What type of sodium channels are inhibited aside from the ones that mediate pain? It must have something to do with what makes obsession go in the brain. Really interesting, but extremely unpleasant. Can be fixed by go back low dose and then use something else to cover the gap, like combine, for example, carbamazepine or trileptal with lacosamide. Still better deal than do everything with trileptal. But that is the one thing. Of course, the other one is with opioids. If patients notice, okay, opioid helps me, but I'm becoming an addict, you need to do something else.
Right. All right. Dr. Leitke, thank you very much for your very informative remarks. I can tell by the Q&A that there a lot of people want more information and they'll be waiting for that follow-up.
I'll get to it. I'll get to it.
So
great working with you, Jeff.
I will bring this to a close. Thank you again for your excellent and informative presentation. That's it.
So welcome.